big one. That's why these are so important. And Professor Youssef, who's just come into the room, is really deeply involved in this. And he's a man that has, and you've followed his career, done many, many clinical trials. And as he moves out into the work in developing countries especially, he's been a real leader in the concept of the polypill, trying to understand how it might work. Salim, we got started. If you'd like to say a few words.
My apologies. I was held up by another meeting. Then these things tend to go on, especially if they're interesting. I think the evidence that using a handful of pills, beta blockers, ACE inhibitors, statins, and aspirin, each reducing future events by about a quarter, is absolutely incontrovertible. What's also true is that their effects are additive, which means collectively they will, if people take it, they will lower the risk by about 3/4 to 80%. Now remember, those quarter comes from trials where there was already non-adherence. So I think it's possible. But in reality, things may not work out the way you want it to, but it could work out that it's 2/3 of what we project. But 60%, 70% is huge. If you combine it with simple lifestyle modifications, smoking, fruits and vegetables, exercise, and you have 90% compliance, we have modeled this and published in the European Heart Journal, you should get a 90% risk reduction in cardiovascular disease. That is huge. Imagine a penicillin for cardiovascular disease. Cardiovascular disease is the biggest epidemic history has ever known. And yet, we are failing to implement it. The polypill is a vehicle. The polypill by itself is not enough. Now, why do people not take these drugs? I presented earlier on today and yesterday and then later today that one is cost. Even generic ACE inhibitors, statins, aspirin are unaffordable in low and middle income countries. Why do I say that? When you think of cost, you've got to think of cost as a proportion of your disposable income after shelter, after food. In the rich countries, even if there wasn't drug coverage, the cost of taking these four is only about 1% to 2% of your monthly income. In low middle income countries, it is between 40 and 60%, 40% in the urban settings and 60% in the rural settings. So when you get somebody with vascular disease, and this is work that a PhD student of mine has done, and we're about to write it up, if then you get people who have to spend 50% of their disposable income on 4 pills, that's a household's income. Remember, somebody else in the household may have other problems. There's clothes to buy, there's school fees to pay, there's transportation to do. Guess what? It's not surprising they don't take it. Now, the polypill, the first thing it will do is it will reduce the cost of these things. The retail cost in India is half the cost of each of these put together. In India, each of these things put together is about 30 rupees. The polypill is marketed at 15 rupees. So immediately you've got a halving. But if the government step in, insurance companies step in and purchase it in bulk, that 15 rupees can become 5 rupees. Imagine 5 rupees, 150 rupees for a month, $2 treatment. So now instead of being 40 to 50% of the monthly income, it becomes 5% of the monthly income without having universal health coverage and all that kind of thing. Now, if that came about, that'd be even better. So I think, and we've shown in that study that I referred to you, that the more unaffordable it is, the less likely people will use it. Second is if you have a single pill that you have to distribute, you have an easier distribution chain management. Procurement is simple. Inventory control is easier. Distribution is easier. Avoidance of waste is easier. So there are all these things. So if this becomes an essential drug, and we have to lobby to make this, the polypill, an essential drug. Antin and I tried, we didn't win, but we're going to try again. If it becomes an essential pill, medication for the control of cardiovascular disease, high-risk primary like hypertension and secondary, and get it on the formularies of every country, find mechanisms of manufacturing it inexpensively, procuring it, and that's where I was at the last meeting, and say we created a public-private partnership where a handful of companies around different parts of the world, like 1 or 2 in Africa, a few in Asia, a few in other countries, agreed to manufacture, but there was advance purchase commitments from the governments and from large insurance companies. Like Kaiser, at least people have said, we'll buy it if there's one there. It'll save us money. And even in the US, money is now becoming a big thing. And adherence is becoming a big thing. So patients stop taking it, the doctors get docked. So I think it's a bloody good idea. Sorry, don't quote the B word, but it's a great idea. So the polypill is a vehicle. You know, don't think of it as a magic pill. It's a vehicle, but you need to tie it with a health system, a business plan. You need to tie it with the delivery of people. Now, if a patient who is stable 3 years after an MI has to go every 6 months to see a doctor and get a prescription, they lose a day's wage. They spend money on that. And then they pay the doctor in most countries. I mean, you know, I live in Canada, Stuart there lives in the UK. We have the luxury of a universal health coverage. We don't have that in most countries. So the overhead costs of getting it is high. And in some countries like Malaysia, they'll only give you pills for 1 month. That's the way it is, 1 month. And then you got to go back. So now let us think of a scheme where instead of the patient going to the doctor, how about somebody going to the patient's home? You know, just like that's the way malaria control, TB control is happening in various parts of the world. And you will hear today in the hotline session, and I'll urge you to go there, a presentation by Dennis Xavier on the spread study. It's not the polypill, but it's a delivery system of using community health workers who go to the home, sit down with the people, educate them on the importance of adherence, on blood pressure, and on lifestyle. And the results are spectacular. They really are spectacular. And these are people with high school degrees with, I think, several weeks of training. So they're really low-level workers. Their salaries are, I don't know what, but if you ask me to hazard a guess, I'd say it's about 8,000 rupees a month. 8,000 rupees is, Anushka, what it would be divided by 50. I mean, more or less. What is it then? $125. Now that is a model. So now combine that, systematic screening, adherence, pill delivered in the home step with a low-cost pill procured by governments at no cost. Voila, we have the penicillin we want. It's a combination of the polypill and a healthcare system. So think of the polypill as part of a system. The polypill alone can't do it. So penicillin is available, or it works for rheumatic heart disease. But why aren't we controlling rheumatic heart disease? Because we don't have a system. So my plea would be, as you write your stories, talk about the story of creating health care systems at low costs involving non-physicians, using fixed dose combination pills. And it's not perfect for everybody, but it's good for the majority. And that's where the polypill comes in. And I think the starting point is secondary prevention. The next one is high-risk primary prevention. We know in hypertension we need to use drugs, and we need to use multiple drugs. And we need to control other risk factors like lipids. The Ascot study, which you published, showed that both worked. And in that study, if you lowered blood pressure and you gave statin, so you had a 50% reduction. So, and that was against usual care, which was 2 other drugs. So I can see this being a big revolution. We need your help. You're not here just to report a story. I'm going to ask you to enlist in the Army. And the Army is, we have to get the message out there that this polypill, along with the healthcare system's change, is going to be big time. And wouldn't you like to be part of that army and tell your grandchildren, I was part of that team that reduced cardiovascular disease by 50%. That's what I'm going to leave.
Now, if this man can't get you to take one pill a day, no one can. That was brilliant. Well put. And Dennis Xavier was one of the abstracts I gave you yesterday in the introduction, so you have that.
Spread is the name of the study.